my name is Al Brahmbhatt. They call me Dr. Al in the ER. I work the night shift in the ER, okay? So pretty much I try to get those wake-up strokes a lot, and so those are where I have to be an expert in terms of trying to determine the right information. And in reality, this is the thing that I'll talk about later, but the EMS is very integral in terms of helping me for the night shift, all right? Because they're the ones that will tell me, hey, this happened this time, and this is why it's going to be integral in terms of doing all the procedures I do later in the ER. So let's get on with it here. All right, so if you had to know some facts behind it, you should know that there's over 800,000 cases in the U.S. per year. That's the U.S. Who knows what it is around the world, okay? 600,000 are first strokes, okay? Number one cause of disability. You know, you look at the cost, it's $40 billion per year, all right? So you might have to even increase that a lot because you look at the other extraneous details such as taking time off work for your family members to come take care of you, or food and all that kind of stuff, hotel costs. I mean, it's easily up there over 40 billion. You're looking at maybe 50. Anyway, so, and 5% of all strokes are the first ones. Sorry, 5% of all strokes are patients in the U.S. get the acute treatment. So 5%, where's the other 95%? We're trying to get them to recognize. And you'll see that if once they see that they have signs of it, who knows what that number will be later on the next 15, 20 years. And, you know, stroke is difficult. All right, it's difficult to treat, difficult to recognize. You know, you talk to a lot of people in the ER. We do always say, oh well, they're dizzy, but you know, maybe not. So that's the difficult part treating stroke. So, and the symptoms are not recognized early, even by the patients themselves. All right, they think their little facial droop, they'll go away. You know, so they won't come seek treatment. So. And a lot of times, the majority of programs out there, they lack the organizational structure, especially in the pre-hospital setting, okay? And it's with the hospital system itself. So for the acute stroke victims, so I mean, granted, we have a great structure in place, and we're actually trying to enhance it by having the symposium. So we're just trying to make sure that it's recognized and sort of take credit for that. The treatment, you know, is the IV TPA, all right? So that's one treatment, but we'll go into other ones later. But you have 3 hours, okay? But what's the risk behind it? You know, it's a significant risk of bleeding. So the other parts of stroke is hemorrhagic stroke. Usually that's a surgical intervention. You know, the fact is you do need 24/7 coverage, okay? You can't have 24/5, you know, 12 and 7. So you really need it out round the clock. So, and you need emergency department stroke centers, okay? You need all the resources such as you need the acute stroke neurologist, you need a dedicated CT scanner right there, okay? You can't have it up 2 floors and try to think you're going to get the time frame for it, all right? You need the acute stroke neurointerventionalist, you need neurosurgeons, okay? You need a program post TPA or everything just to have that in place. Let's go into just talking about stroke in general. So if you have to know what stroke is basically you know, you have ischemic stroke, where is interruption of the blood flow, okay? Secondary to, you know, thrombus or embolus, as you see. And it's basically an area that's deprived of oxygen-rich blood. And, you know, you have the 2 types. You have the thrombus, all right? That's something that it's a clot that forms within the vessel and prevents the blood flow and creates that ischemic insult. So you have the embolus. Basically, that's a clot that travels from another side of the body, goes up, lodges within the artery of the brain. Now you got the hemorrhagic stroke. Okay, basically that's an artery that ruptures and bleeds into the brain. Okay, I'm going over scientific details well, but I also want to get into other parts of the whole program on top of all this. And it bleeds basically, and you have intracerebral bleed or you have aneurysmal bleed, subarachnoid. That's an intracerebral bleed. Oh, gotta use my pointer. Right there. I always want to use that. I never get to use that. TIA. Okay, this is the one where this is very key for EMS. I want them to know that TIA, like if they tell you they had these symptoms, all right, and they say, well, I'm better now, and so I want the EMS to say, hey, this is what they had, this is what they complained about. So it's very integral for the EMS to see that they had an event of a TIA. And if you really look at the reading, you know, the mini strokes they call it, basically it's where the cerebral artery is temporarily blocked, not fully blocked. Obviously that would be ischemic stroke. And if you look at the stats right there, you know, 35% of patients with a TIA will have a stroke in the next 5 years, all right? Out of that 35%, 70% will have it within the 2 weeks of a TIA, all right? So that's a pretty significant thing to tell them, you know? So you want to tell them, hey, don't blow this off because you never know. So, and if you look at just the numbers behind it, out of that 700,000, 87% are ischemic strokes, and the other 13% are technically the hemorrhagic strokes. You have, if you look at just the pie chart breakup, most of them are thrombus, okay, that's 61%. The other 24% are the embolus, okay, and the 3% are TIAs. And you look at the stats for the intracerebral and subarachnoids are there too, so that's the other 12% of it. Look at this. I found this on the CDC website. And if you look at it, and you look at Alaska, you know, those are the numbers of stroke deaths, okay? Very high percentage, and that's more based on the fact that they're just the population base. So look at down here in the south. So, man, I mean, we're lucky in Florida, I guess. So it's not as many stroke deaths, probably because we have a great program. So that's what it is. But you know, also the northwest. But if you look at the population up here and down here, that seems to be the concentration of where most of the deaths do occur. And what are the risk factors? You know, stroke is the 4th leading cause of deaths for Americans, okay? Risk of having a first stroke is twice as that for, you know, the black population than for whites, and they're more likely to die following a stroke than whites. If you look at Hispanics, they're in the middle there somewhere. And if you look at the fact that Indians, Alaskan Natives, like we saw on the chart, all right, they're more likely to have a stroke than any other group, okay? If you look at although the stroke risk increases with age, strokes can and do occur at any age, all right? So 34% of people hospitalized for stroke were younger than 65, okay? So, and if you look at one of the other stats that's coming up later, I'll show you that modifiable risk factors, hypertension, diabetes, these are things we can all control, help ourselves, take the medication, watch your blood sugar, you know, make sure your cholesterol's in check, stop smoking, okay? Alcohol consumption, you know, I'm talking about everyday consumption, not like socially or anything. Like 1 glass of wine is what they say is heart healthy. Carotid artery stenosis and abdominal obesity, okay? Not modifiable age, gender, race, genetics, okay? You look at the little cartoon there, you know, exercise is a key, it will help you through all of this. Unless you want to die, no, that's what it says. Cardiac risk factors, you have AFib. You know, that's probably the number one cause for the embolus. So you got the MIs, the valvular heart disease, and endocarditis. Common causes for intracerebral hemorrhage, okay? Think about it. Those are hypertension. That's actually number 1. That's 85% of all intracerebral hemorrhages, okay? Then you have the amyloid angiopathy. Basically, there's amyloid tissue that deposits within the brain. That, surprisingly, is number 2. So, and you have the other use of anticoagulants. You're talking about Brilinta, Xarelto, Coumadin, those kind of things. So, CT scan showing the bleed itself. You know, you have the bleed right intracranial hemorrhage here, a little mass with the mass effect here. I'm sure there'll be plenty of other pictures from the other presenters, and they'll show you a lot more detail as well. The neuroanatomy. This is the one I'm going to quiz you on. No, I'm not going to do it. So every time, you know, when I used to do rounds in residency, and the attending will look at all these residents in front of me, and it's like, all right, he's going to answer this question. Now I'm looking at him, it's like, you know, I don't think I know that answer, but I'm hoping to use my Jedi mind trick so he just looks right past me. So didn't work, so we got in trouble. Arterial dissection. So you have basically the carotid artery dissection. It's basically a separation of layers, and you see that it forms like a area that's just blocked off, so it creates a temporary blockage. So non-ischemic signs are headache or neck pain. So, you know, in the ER, oh my God, how many people come with headache? I'm like, well, do I think it's a dissection first? Not necessarily, but you got to look at the whole context, what they're telling you and everything. And ischemic signs, obviously, this is the thing, the vision loss. You know, we get a lot of patients, oh, I got blurry vision in one eye or both eyes, and you're like, is it psychogenic or is it real? You know, so we have to like, that's why it's difficult. That's why you have to really just get their story and sort of just understand what's going on. And you know, just the anatomy of it, the vertebral arteries in the posterior part of the neck, and that leads up into the posterior part of the circulation. And you can see the little famed circle Willis there. And you look at the 3 areas: anterior cerebral, middle cerebral, and posterior cerebral. I'm not going to, you know, harp too much on that, so I just wanted to show you the picture. It's a nice picture I got. If you look at that, okay, so when you have these areas that are insulted, the middle cerebral or posterior and anterior, you look at where the areas that they will affect. Middle cerebral is a big one, right? So you see that will affect the face, tongue, hand, arm, but there's a component that will, if you do the anterior cerebral, do the arm, leg for motor, all right? And then if you look at sensory, same thing. And now this is a big one too, the lenticulostriate arteries. Those are the arteries of stroke, okay? Those are right up from the middle cerebral artery. And those are the ones we use for our perfusion studies and CT angiography and try to really find what's going on and try to get them right up to interventional radiology at that point. So left hemispheric stroke, okay? Language, you know, the ability to speak, they're aphasic, all right? Right hemiparesis, right sensory loss. Left gaze, difficult reading, writing. I mean, those are all things that you will want to see if you are looking at somebody who has those symptoms. So, okay, do they have a language issue, aphasia? Is their right side off? Or left? And remember, left hemispheric stroke, big thing is left will always look left gaze. Okay? So if somebody's only gazing one way, let's say left-sided, then you know it's a left-sided stroke. Same thing with right stroke, you'll have right gaze. So, and they'll have left-sided sensory deficit and left hemiparesis. Aphasia, expressive aphasia, okay? You got motor problems, you understand but can't get the words out. I call that my marriage aphasia because I know I want to say something but it doesn't come out. So, and receptive aphasia is more the sensory problems where they don't understand or they're speaking but they're just not making sense. So, and dysarthria is just slurred speech. And it's a motor problem mainly. And then you have the cerebellum. Basically, that creates one-sided malfunction, all right? So whereas coordination, balance, equilibrium, and ataxia. So, you know, they're almost like they're drunk. So, and then you have the brainstem, which is the posterior circulation. And you have the signs of brainstem. The brainstem stroke, if you think about it, is the one where they say it's a locked-in scenario. So they have hemiparesis, abnormal eye movements, dysphagia, and with nausea and vomiting. This is the part for EMS I want everybody to understand. For stroke symptoms, you know, when you ask the patient, they're going to have sudden confusion, trouble speaking with understanding. There's sudden headache as well, all right? Sudden trouble seeing in one or both eyes. Sudden trouble walking with dizziness, loss of balance, coordination, numbness or weakness of the face, arm, or leg, especially on one side. So, you know, a lot of patients, when they come to me and they say, well, I can't feel this, you know, it's like, well, you know, let's look at what's going on, you know. So it's a complex of whether it's really stroke versus a lot of other symptoms that are out there. Could be electrolyte deficiency too. All right, for the EMS, so after all that information, all that stuff that's going on, what do you think, what do you need to do, you know? So as a quick example, you know, you have a 70-year-old male with severe headache, decreased LOC. The wife is basically trying to call EMS and said that, look, he's just out of it, and he's drooling now from the right side of his mouth, and he was just fine just a few minutes ago. And what do you want to do as an EMS person, EMT? You know, what are signs and symptoms? What is your differential? You know, that's a key thing right there. You know, did you do your tips and valves? You know, is it a trauma? Is it an infection? Is it psychogenic? Most of the time we're probably going to think that, but hopefully we're trying to be more serious about it and say, hey, this could be something real. Seizure, syncope, you know, whether AEIO is you, alcohol, electrolytes, insulin. That's why we always ask for a blood sugar check. Opiates, you never know. You know, check for the pupils. Uremia. And then, you know, look for your stroke signs and symptoms, your left hemisphere problem, all right? So speech, all right, you got aphasia, dysphagia. The right hemisphere is speech with dysarthria, all right? Other conditions, check for the hypoglycemic state. Are they post-ictal after having a seizure, all right? And check, you know, if it's subdural epidural, you know, they're going to have, you may not know that at that time, but it could be something that you have to put there in your differential. So, you know, your Cincinnati stroke scale that most of you guys employ with is a droop, drift, and speech. All right, so you're looking for all that. So, and as far as the community, you know, we want to get it out to the community to think about this. So it's so key to educate the community so they understand these symptoms, so they can say, hey, you know what, I'm having some of these things going on. So we want to get them into that whole system right away to 911. So, remember, we're trying to get it out where they have the 3 hours. So they can understand time is key. You know, for EMS, make sure you're checking for the droop. Basically, normal is both sides of the face look normal, like square up on them, take a look. Abnormal, one side of the face looks a little bit droopy. Then the drift itself, ask them to raise their hands. So you'll see that one will drift compared to the other one. And just have them talk, you know. Can't teach your old dog new tricks, some other pattern, what's your address, anything like that. Then the key element here is this one, time last known well, you know. But the whole thing I want to point out is take the scenarios seriously, because time is brain. Because, you know, whether, you know, if they just have a numbness, think about what it possibly could be and go from there. And then, you know, basics for EMS also. I'm not going to teach them that, but you should know, you know, scene safety, body substance isolation, initial assessment, their ABCs for airway, breathing, and circulation, and then focus, history, and physical exam. And you can do your secondary while you transport them. So this is the key thing I wanted to get out of all this. Last known well. So if a lot of you guys know that when you guys come to the ER and I'm there, I'm asking them, hey, what's your story? What's going on? What happened to them? We have family members, you know, and so the key part that the EMS will play is getting that information to us. So you'll see that, you know, ask questions. Did they wake up like this? When would they last normal? Any symptoms yesterday? If there's persistent symptoms, get them in here. You know, so I did, you know, just looked at some journals as well, last known well, when you compare the EMS last known well versus the neurology last known well. And it was actually very highly reliable for what the EMS reported to and what the neurologist got. It was the wake-up strokes that was more difficult. That was more variable. So, and you know, some systems actually do consider waking up is when it starts. Technically, no. But, you know, so that's where the whole system has to get together and confirm that it's not that, it's something else. So, and the bottom line, EMS and stroke center need to be on the same page if you want to actually get the program up and running in any system out there. So, and one of the key things I didn't put on there was phone calls, right? If you know that you have a relative, husband, boyfriend, anybody, we need them. You know, they're part of the whole story. All right. So if you can get their cell phone on the way in, is what I'd encourage a lot of my EMS friends out there. Give me the number so I can call them, because a lot of times the neurologist also wants to talk to them too, because they have their series of questions they want to do as well. So, you know, what you need to do right away, just get just recognize, all right, get the EMS dispatch ready to go, transport, pre-hospital notification as well, and then get them to the primary or comprehensive stroke center. If you think time's a factor, and they're, you know, you can't get them to comprehensive because you know that time's an issue. Get them to the primary stroke centers, you know, with Altamont, Celebration, Kissimmee, and East as well. So try to get them there, because we know we have the time window for the 3 hour for TPA to get them into that one location. So, and rapid diagnosis and treatment in the hospital. And the steps basically just last known well, like I harped on, and the neurodeficit, check their blood glucose, and just let them know when you're getting out to the stroke center, all right, as well as the ED report. Now, some of the new things that are out there, the University of Texas is doing this mobile CT scanner. As I was reading, I was like, oh, I find it very interesting, you know, to put a CT scanner in the ambulance, okay? But in the ambulance, you'll have a neuro team, paramedic, nurse, neurologist, and CT tech. So it's a little crowded in there, I think. But they retrofitted the whole ambulance. So they basically made it bigger. They had to do it from the ground up and redesign it completely. And it's in the Houston area, so it's within a 3-mile radius. So it's not really going out 20, 30 miles away or anything like that. And then they'll get the TPA within the ambulance too. All right? What is the reason behind it? Time is brain, obviously. So, and then the question about the neurologist being on there, if anything, they may just incorporate telemedicine like you're going to see today. So. And, you know, one of the things we have in the ER is where EMS transmits the STEMI EKGs to us, and they wind up actually shortening the door to balloon time because of the fact that EMS is incorporated or helping to expedite care, all right? And so in the end, that helped in terms of changing our whole STEMI program in terms of shortening the time frame. So what about teleneurology? Can we do the same thing? Put the little, you know, the televideo within the ambulance and get a, you know, emergent conference right there. But the question comes down to, it's a new role. I mean, televideo for neurology is really in the last 6 to 10 years. So, but it's changed immensely, and it helps a lot. So I used it in Zephyr Hills when I worked out there. We also did telepsychiatry. So that helped. Is, you know, intoxicated people like, I want to hurt myself. No, you don't. Okay, I don't. So and goal should be to deliver neurology consultation services right away in the shortest possible time so we can actually expedite the care of the TPA if we can give it to them. Well, the question comes down to is that, well, are you going to get the TPA in the ambulance based on the EMS is going to give it, or are you going to have a trained personnel for it as well? All things that need to be worked on for the future. So, but at least the question's out there. So they may come to fruition. Who knows when, but it's something that's there. All right. The ambulance cost $1.1 million. I don't know what a regular ambulance costs, but it was like $1.1 million. So I know. So, and then as for last known well, you know, it comes down to where are we going to get a standard set for them, where when the EMS personnel arrive on scene, ask these 5 questions like you have FAST, right? Cincinnati stroke tale. You have the same thing for last known well at the same time. And you know, one of the things, if you look at these statistics right here, it's working. You know, if you look at here, you know, look at 2011 for home and rehab. We're getting there, you know, with expedited care into rehab 63% of the time. But guess what? As we get better and better at what we do, we're up to 72%. That's billions of dollars saved right there, getting somebody home. So, you know, less people are going into hospice, and then you also skilled nursing facility, 18%. That's a big drop. So, and you know, final thought, the EMS role is a key. All right, this is why I'm going to keep on harping on it. Every time I'm working the ER, I want to let people know, hey, you know, you guys are integral in terms of the whole introduction of the patient into the system, and your time is key for helping all of us. So that pre-hospital information is immense. So, and a rapid transport, that's the other thing too. And new roles, I mean, the mobile CT scanner, I don't know, you know, but it's trialed, and we'll see, get some numbers later on. When they just started it this year, so, or end of last year. And as far as pre-hospital TPA, that, you know, you would need probably teleneurology within the ambulance to really consider a TPA at that point. I know we have, when we do TPA, we have to, like, you know, measure it out, get it all together. It's like, well, if you're going to try to do that in the ambulance, it's like, well, maybe it's going to just be a vial, and that's that. You know, like where they don't do any mixing, it's ready to go. Final thoughts? Anything? Any questions?
Questions, anyone?